and I'm so excited to be here with Dr. Kim Millman. And Dr. Millman is an integrative physician, and she's been working with osteoporosis for over 15 years, really successful practice. And she also started an amazing course called Restore and Rebuild 100 Days to Healthy Bones. And oh my gosh, how many years now, Dr. Millman, has course been going on?
It's 3 years.
Yeah, 3 years and many people and so many lives were changed. And I feel so excited because I was the one that said, Dr. Millman, a lot of people want to see you. Is there any way you can do a course? So I feel a bit responsible for this. But anyway, and she also, Dr. Millman and I are both, we both recently started we founded and started the Bone Health Academy. And we're training practitioners on the Certified Integrative Bone Health Practitioner Program. And our first cohort of amazing practitioners is finishing in March, and we're going to be starting another cohort. So this is just for practitioners in May. So we're really excited. Anyway, okay, so what I'm going to do, I'm just going to change my view here. So this will show. So if everybody wants to show their video, we have lots of people here, which is so much fun. And for those who are in my community, you know the ritual. But what I want everyone to do is put an intention out there that they're going to get something from today that's going to help them, that will help them on their journey. So put an intention out there, number one. And then we like to juice up Dr. Millman. We like to get the juice going. So what we're going to do is we're just going to all unmute and just say, hi, good energy. So we get the energy flowing. Okay, is everybody good about that? All right, so unmute. One, two, hi.
Hello.
Hi,
Good
good
energy.
energy.
Oh, good energy.
Thank you.
Hello, hello.
Hi.
How's
We're
that kitty
doing
cat?
this.
Hello.
How's that kitty cat?
Hello. Good energy.
Oh, I love it. How juiced up are you, Dr. Millman? Oh my goodness.
Feeling great.
Right? Okay, so now we can all mute, and I'll be muting people too. And I'm going to just turn this over to Dr. Millman. I'll be chiming in too, but I'm going to turn it over. And as I said, there is going to be time to ask questions afterwards. So how do you want people to do it? You want them to just raise their hands later? What's the best way, Dr. Millman?
Raising hands is the
Okay,
best
so don't
way.
worry about
Yeah. It's hard. It's really hard to follow the chat for
It
us.
really is. It really is. So
Yeah.
yeah, so the best thing is I will be looking at the chat, but the best thing is if you have a question, raise your hand and we'll save the hand raises to
What's going on here?
Okay, and I'll mute
Eileen, you were having problems with the audio before. You are no longer having problems with the audio.
All right, Dr. Millman. So I'm going to get out of the picture for now. I'm going to leave it up for you. And let me get my pin, remove pin. Okay, and I'm going to, you are on, Dr. Millman.
Okay. Can everyone see my screen? Can see the big slides?
Yes.
That's awesome. Okay, so I want to welcome everyone to this Essential Lab Testing for Unbreakable Bones webinar. So this webinar is for someone who has bone loss, who wants clarity on root cause testing that can help you identify what you can do to stabilize.
Dr. Millman, you're muted.
Oh, I muted you by accident, so start again. Okay, unmute. Okay.
Yes. Are you saying Mimi? No, back for more minutes.
Oh, I muted everyone. Let's start again here. Okay, Dr. Millman, you're muted. Unmute yourself. Okay, you're good. Okay, start again.
All right, so I'd like to welcome everyone to this Essential Lab Testing for Unbreakable Bones webinar. So this webinar is for you if you have bone loss and you want some clarity on how to do root cause testing and some of the essential testing that you need to do to be able to follow what's going on with your bone health and what you can do to stabilize or even reverse your bone loss. And even if you don't have bone loss, this could be helpful for also evaluating where your bone health status is. So the type of lab tests we're going to cover today include the standard tests that are usually done at your doctor's office, and you can get these done at LabCorp and Quest. And these you might do as part of your yearly physical, or your endocrinologist might do these tests. And we're going to go over these tests. The second type of tests include labs that are also done at LabCorp or Quest that really dig deeper. And an example of this might be that, let's say that you're evaluating your blood sugar and you have a fasting glucose, but you don't have an A1C, you don't have a fasting insulin, you don't have a triglyceride to HDL ratio. And so these would be digging deeper with just using LabCorp and Quest kind of services at your with your assessment. And then the third type of testing would be functional lab testing. And these kinds of testings are going to look at food sensitivities, or your hormones, or your cortisol level, looking at your microbiome and digestive analyses. And all of these tests, I think, are essential to really evaluate where you are with your bone health. And these are tests that I do over again in my practice, and also I teach them in my Restore and Rebuild program. So let's look at many of the root cause tests I offer in my patients for people with bone loss, or even for people who want to improve their overall health. So let's just say that bone turnover markers are a game changer, and they are absolutely essential for you if you want to have a real-time analysis of what's happening with your bones. You want to know how quickly your bones are turning over. So we have C-telopeptide, or CTX, and this is your bone breakdown marker. And then we have propeptide of type 1 collagen. This is P1NP, and this is your bone formation marker. And we not only want to know their absolute values, but we also want to know how they compare to one another. So they're really helpful for you to have a baseline. Where am I when I'm starting this process? And then you can guide your progress through some sort of a root cause therapy protocol. And you can recheck these bone turnover markers and see if they are moving in the direction that you hope them to move. The other thing is that certain root causes will affect P1NPs, and other root causes will affect CTXs. So if your CTX is high, then you're going to want to make sure that you address those relevant root cause factors, and also the same with P1NP. But these are absolutely imperative that they be done properly. So CTX is the highest at 5 o'clock in the morning, and it is the lowest at 2 p.m. in the afternoon. So when you take this test is absolutely imperative, and because we want to catch the highest value, you do it as early in the morning as possible. And then you do it at the same time during the day when you're repeating it. You want to make sure that you don't have any collagen or bone broth that you are taking before at least 48 hours before the test. And the reason being is that these tests are looking at the collagen breakdown of your bones. So if you are taking collagen the morning that you take your test, you are literally measuring the collagen that you just took. Also, biotin interferes with the assay, and strenuous exercise interferes with the assay. So you want to absolutely make sure that you do these properly. Otherwise, they are worthless. And I really believe that this is one of the reasons why, a couple of different reasons. One reason is that doctors don't do these tests is that one reason that doctors don't do these tests is that they don't know how to instruct their patients properly to have accurate tests, and they also don't know how to interpret them. Now, this webinar is not about interpretations of tests, so we're not going to be going into that, but this is something that an experienced expert in osteoporosis will know how to do. I have been doing these for almost 10 years. And I know how to follow these. I know how to use them with great finesse. And there aren't many physicians out in the country who actually know how to do that. And Margie, would you agree with that assessment that this is the area where it can kind of make or break you, and it's hard to find somebody who's an expert at it?
Yes, and it's so, so important. That's what I've seen in terms of, it really changes changes your what we do. It just changes your whole treatment plan and you get so much information. And what I have found is that the doctors who weren't doing it and have started doing it, they really can see the benefit. But it's true, there are not people that have done it year after year and feel comfortable. So oftentimes they may say, "Oh, I just don't do this task." But we've taught people that you ask for it and you get it, and because it really is helpful.
Yeah, and even in Restore and Rebuild, I teach how to interpret these tests and how to use them in multiple ways in what you're doing to take care of yourself. So, and to advocate for yourself. And I think that is the other part of it is that um, you you need to know what to ask your doctors for, right? So this is absolutely something that I would recommend that everyone gets a CTX and a P1NP, and so that they can monitor their bone breakdown. And and then the other thing that is absolutely imperative is you have to be ruled out for hyperparathyroidism. So the parathyroid glands are sit on top of your thyroid. There are these four little rice-sized glands, and they're your calcium sensor. So we know that the bones need minerals, and calcium and magnesium are the primary calcium, magnesium, zinc, boron are your primary minerals, and the health of the parathyroid glands is absolutely essential. You don't want to have these parathyroid glands that are overactive for any reason whatsoever, or your bones could be breaking down very quickly. And there's primary hyperparathyroidism, which is based on these little glands being hyperfunctioning, and they might have a little tumor on them. These tumors are nearly always benign, but if they are serious enough, they need to be removed. And if you don't get them removed, then your bones will literally just disintegrate. Margie has a lot of experience with working with Diva Boone, and maybe you can tell about all the people who have like just absolutely um, benefited from this knowledge. Oh, Margie, you're muted.
This is so important because each summit I had, and I've had four, around 20 people listened to Dr. Diva Boone's talk, and she mentioned looking at your calcium values and your blood calcium value. And if you're over 40 and it's over 10, that is a red flag. But a lot of conventional doctors, for some reason, they just don't learn these numbers in medical school. And there's a wide range because if you're young, 20, it might be okay, but it isn't. So around 20 people each summit found out they had this, had the surgery, and that's the cure for this. I mean, really, they just removed, and you need to go to a surgeon who does this. But the point is that this was missed. So for years, they were losing bones. So it's so important. And that's why we teach to look at your blood work and look at your calcium levels. And yeah, so I would say probably 80 people altogether, found out that they had this. So really
Yeah,
important. Yeah.
I think that's incredible. And in my practice, I find it all the time. And so when you look at the calcium levels, I'm going to delve into a little bit of interpretation. So 8.8 and anything like 8.8 would be too low of a calcium. So we want the calcium to run around 9.2 to 10. And anything over 10 is suspicious for hyperparathyroidism. And what traditional medical doctors are taught to do is, first of all, you get the triad of parathyroid hormone, calcium, and vitamin D. And so they're taught that if parathyroid hormone is within range and calcium has to be over range, which is 10.4 or above. So let's say the calcium is 10.4 and the parathyroid is 50, then there's no hyperparathyroid disease. But if the calcium is 10.4, the parathyroid hormone should be so suppressed, it should be 30. It shouldn't be 45, it shouldn't be 50. And so by knowing these numbers, you can actually tell whether you potentially do have hyperparathyroid disease. Diva Boone has a calculator where you can put in your levels of parathyroid hormone and calcium and your age, and she'll actually give you an analysis. And I know that many parathyroid surgeons, if your data looks suspicious, again, any calcium that's over 10, and that would be paired with a parathyroid hormone that's probably over about 35 or 40, even though that's within range, it's suspicious. And a lot of parathyroid surgeons will actually do a free consult and let you know what they think about your numbers. So that is absolutely essential. The other thing, so that's primary hyperparathyroid, and secondary hyperparathyroid would be if calcium or vitamin D is low. So calcium would be anything less than 9.2 would cause the parathyroid gland to say, hey, we need more calcium from the bones. We're going to push it over into the blood. And that would be causing a secondary hyperparathyroidism. No matter what, calcium's getting leached from the bones. When vitamin D is low, that causes a secondary hyperparathyroidism. So these three lab markers can tell you where you stand with respect to parathyroid disease. The other thing is a renal leak. So renal leak, so that the kidneys should be absorbing about 98% of the calcium that gets filtered through them. And when there's a high amount of calcium that is being lost in the urine, it can be from multiple things. The way that we measure this is a 24-hour urine calcium, and it's imperative that you don't take calcium supplements for 3 days prior to the testing. And when this is high, it can be a couple of different root causes, including something called metabolic acidosis, which can be from toxicity and inflammation. That's the most common thing. Taking a medium dose potassium and electrolytes can help to reduce that. But having a 24-hour urine calcium, a vitamin D, a calcium, and a parathyroid hormone is absolutely essential as a baseline for you. And I do it for my patients with bone loss every year, every single year. And all of these tests are available at LabCorp and Quest, and you should be able to ask either a primary or your endocrinologist for these tests. Okay, then we want to look at the essential bone nutrients. So we've got a lot of minerals that we want to look at: calcium, magnesium, zinc, boron, phosphorus. We also want to look at vitamin D, like we said previously, and the B vitamins as well. Most of the time, the levels of minerals that are in the blood do not accurately reflect the tissue levels. So I typically don't measure them. And I do measure calcium, I do measure magnesium, and I do measure zinc sometimes. But the other thing is to know what your B vitamin status is. So that when B vitamins are low, B12 and folate primarily, then there is an inflammatory marker called homocysteine that can go high. When homocysteine is over 15, increased fracture risk happens. So we know that this is an important part of the bone remodeling pathway. And so we measure MCV and homocysteine to determine where your B vitamin status is. And then there are oxalates, and oxalates are anti-nutrients to the bone. And so in R&R, we have an entire bonus module on oxalates and teaching you how you can strike a balance between eating some of the oxalates that you love that come from primarily from plants, and also protecting your bones. But just to let you know, if you've never heard about oxalates before, they're like these little shards of glass. They're inflammatory. They lodge in all tissues, and they deplete a lot of the nutrients that you need for your bones. And that includes calcium, magnesium, potassium, phosphorus, zinc, and some of the B vitamins. And so you can measure a 24-hour urine oxalate level and a 24-hour urine citric level, citric acid level. Citric acid helps to mitigate the oxalates, and so you measure both. This is kind of low priority for me in my practice, but learning about oxalates and learning to have a diet that strikes this balance, I think, is super important. And getting homocysteines and MCV is just in a complete blood chemistry. So that's like probably in one of your physical one of the labs that you would get in your physical. So those are things that you can ask your primaries for.
Dr. Millman, could you just say, which is so interesting, because both Dr. Millman and I, we hated this oxalate conversation for a long time. But why don't you say about some of the people in R&R, what happened when they reduced their oxalates? It's quite amazing.
Yeah, so one of the things is that oxalates cause pain anywhere, and it's migratory, tends to be migratory pain. I've had multiple students who have reduced their oxalates, multiple patients too. And they one of my students, one of my patients was she 90% of her neck pain went away, and she was a chiropractor. So, they know how to like, get the mechanical stuff figured out, but what was left was dietary, and she was eating spinach smoothies every day and with almond milk, and she was eating a lot of Swiss chard, and basically, one half cup of spinach is 760 milligrams of oxalates, and you can only get rid of 250 milligrams of oxalates per day. So here she was accumulating oxalates, thinking she's doing the right thing, having a super healthy diet. The other thing is that it's very specific for the urinary tract. As you guys probably know, the calcium oxalate crystals are what is the major form of kidney stones. And so the oxalates have a preference for the kidney and for the bladder. I had multiple people who had these recurrent UTIs, and when they stopped or when they cut their oxalates down in their diet, those recurrent UTIs went away. And some were just so thrilled because they were taking antibiotics, every other month, and they were confused because sometimes there would be bacteria there, and other times it was completely clean. So there are some suspicious symptoms that go along with oxalates, but because they lodge in almost every tissue, their symptoms are very non-specific. So, but it's a yeah, and I never wanted to touch the subject because I didn't want to tell people to stop eating, healthy plants. And a lot of the healthy plants we love, like spinach and Swiss chard and almonds and beets. So I got to the point where I couldn't ignore it anymore. I just couldn't ignore it. And Hippocrates said 2,500 years ago that all disease begins in the gut. So we do take a deep dive into gut function with a functional medicine test called the GI map. And not only does it evaluate the balance between your friendly and unfriendly organisms in your gut, but it also looks into these intestinal markers, your ability to break down fats, your ability to break down proteins, how inflamed your gut is. how much leaky gut you have. It is really just an enormously helpful test. And so, if anybody has GI complaints, this is somebody that you absolutely would want to get a GI map. The symptoms like constipation, diarrhea, bloating, heartburn, or even if somebody has autoimmune disease, because you always, always, always start at the gut with autoimmune disease. And gut issues cause systemic inflammation and break down the bones. And gut issue and these kinds of systemic issues can cause headaches and anxiety and brain fog and mood disturbances and sleep disturbances. So the GI map is something that a lot of my patients, and we teach it in R&R, get to evaluate their root causes. So I'm going to just give you a couple of slides that show you what the GI map report looks like. So this is your probiotics. These are your good guys, your commensal keystone bacteria. And we don't want them to be low and we don't want them to be high. We want them in a Goldilocks, a kind of range. And so we look at all these greens. So this person has 1, 2, 3, 4, 5, 6, 7 greens out of 9. That's pretty good. And so I would be happy with this report and think that the person has pretty good diversity in their gut. This is the opportunistic bacteria that are overgrown in the gut. And this person has 1, 2, 3, 4 reds, which are exceptionally high. This Pseudomonas exceptionally high. Pseudomonas is a gram-negative bacteria that can cause a lot of different problems when it's overgrown. It can cause systemic inflammation. And this Pseudomonas is so overgrown here. It is overgrown by 1,000 times. And that is quite high. And when the overgrowths are that impressive, then you need to do something to eradicate these bacterias. And we do this with herbal combinations. And then the intestinal health markers, they are so incredibly helpful. Steatocrit is the amount of fat that is in the stool. Well, if the fat is high in the stool, it means that you're not absorbing your fats. And we have a lot of fat-soluble vitamins like vitamin K and vitamin D that are so important. Vitamin E that are so important. You're probably not absorbing those fat-soluble vitamins. So when this is high, we give a digestive enzyme that has lipase in it, and it just changes so many people's cases. Elastase is digestive enzymes capacity from the pancreas. A lot of people have low elastase. When they add some digestive enzymes, it changes their digestion. Beta glucuronidase is very interesting. It basically interferes with detoxification of toxins and also hormones, and then hormones recirculate. So this is interesting to know where your beta glucuronidase is. You want to know if there's blood in your stool. Secretory IgA is the army of immune cells in your digestive tract that protects you. If that's low, you want to know that. This is a measure of how you're reacting to gluten in the gut, and this is a measure of, this is eosinophils, so this is allergies to different things. Calprotectin is inflammatory, and zonulin is a molecule that shows if you have a leaky gut. This person has an extreme leaky gut. We also look at food sensitivities and intestinal permeability. And in my opinion, everyone with bone loss should be evaluated for sensitivity to gluten and dairy because they are so absolutely common. And the test that I use, because of its increased sensitivity and increased specificity, so knowing whether or not it really is wheat or it's not wheat and it's not showing up as wheat, but it's really a different grain, is the food zoomers. And so any food sensitivity can cause inflammation and digestive issues. So you should get tested if you have digestive problems, autoimmunity again, and some of these symptoms that can be caused from inflammation from the gut, headaches, mood issues, neurologic pain and weakness, etc., and including bone loss. This is a patient Zoomer results. So these are the high reactivity foods, including dairy and wheat. And she had moderate reactivity to green peppers and kidney beans and quinoa and buckwheat and corn. And then she had a moderate leaky gut and to sorghum. And after these sensitivities are known, then a person can take these out of their diet and can really heal their gut and calm down the inflammation that is not only affecting the gut, but it is also affecting their bones. So blood sugar and insulin resistance can cause increased fracture risk. Even having prediabetes can increase your fracture risk by 24%. So we don't just look at fasting glucose, we look at A1C, insulin, HDL, and triglycerides as a measure of insulin resistance. And ideally, you would do this yearly or even more frequently if yours is not optimal. Continuous blood glucose monitors. These are real-time, you can get real-time evidence of how different foods are affecting your blood sugar. And you can employ different ways of dampening your glucose spikes, and you can see if they're working. And the kind of blood sugar hacks that we teach in R&R is using apple cider vinegar, taking a walk, deep breathing, having eating fiber first, and having lots of fiber in your meal, and eating carbs last. So you can see not only what are the foods that if you wanted, like, let's say that you have an apple and the apple, your baseline sugar is 100, and after you eat your apple, it goes to 150, which is too high. You could add some cashew butter and you could see whether that dampens that blood sugar swing. And if it does, then that can be a strategy for you. And if it doesn't, maybe you have to take apples out of your diet for some time. Inflammation is obvious. That's a root cause for bone loss, and we measure highly sensitive CRP. And his highly sensitive CRP could be completely optimal, and there could still be inflammation, but this is one way to measure where you're at. And also, this is something that you can get from your primary care physician or your endocrinologist. Hormone deficiencies are an absolute game changer when they get rectified. With the data from the WHI studies, we really, the data showed that there was increased breast cancer risk with estrogen, and this has since been debunked, and the new data has come out and that estrogen actually decreases breast cancer risk. But it's a good idea to know where your hormones are at. Now, I would say that most of my postmenopausal women who are quite a few years out from their final menstrual period are going to have very low hormones. This is going to be a root cause of their bone loss. And whether or not they want to do bioidentical hormone replacement or not, that is all a huge personal decision and based on risk factors and based on other things. But you should consider just getting some baseline hormone measurements to see where you stand. And especially if you have symptoms of low hormones like brain fog, insomnia, hot flashes, and achiness. So there are various ways that we do hormone testing. You can get blood levels, and these are the least expensive. They're really good for following hormones, and insurance often pays for them. Now, if you are a postmenopausal woman, you need to get a sensitive estradiol because we want to know A non-sensitive estradiol will let you know if you're 15 or above. And if you're below 15, it'll just say less than 15. We want to know if you're 2.5. We want to know if you're 5. We want to know if you're 10. And so if you're a postmenopausal woman, it's important that you get a sensitive estradiol. And then if you're a man, it's important as well to get a sensitive estradiol. For women, you want to get a sensitive testosterone, and then you want to get DHEA sulfate. I do blood level hormone testing a couple of times a year if people are on hormone replacement to just make sure they're in a safe range. Now, if you just as a baseline, if you wanted to do a saliva hormone levels, these come with cortisol. They're not good for actually following hormones if somebody's on replacement, but they are good for a baseline. And I get the ZRT Female Hormone Panel 3. And then the most expensive, most comprehensive comes with the cortisol, good for following hormones, is dried urine. And I get, the Dutch Plus for this. So this is an example of a saliva hormone panel. This is the ZRT Female Hormone Panel 3. And this is the estradiol levels and plotted against age. And the green curve represents optimal levels, and the top red curve, if it's above, it's high, and the lower red curve, if it's below, it's low. And so this was a patient who had low normal levels of estradiol, progesterone, testosterone, and low levels of DHEAS. This is an example of a dried urine Dutch Plus. And so we have this dial, and the little purple box is the postmenopausal box. And the first star is the premenopausal range up until the second gold star. And then beyond the gold star, this is a high level. So in this instance, my patient had a lower than postmenopausal estradiol, same thing for progesterone, same thing for testosterone. Her DHEA was also low, and you can see that this cortisol curve was very abnormal. And I'll show you cortisol curves in a little bit later. So high levels of the stress hormone cortisol can break down your bones very quickly. So stress is a common major contributor to both just illness, decreased quality of life, and to your bones. So you should consider getting cortisol testing if you have bone loss or symptoms of high stress, like anxiety, insomnia, heart racing, palpitations, and irritability. And there's two different cortisol testing options that I do. I do the ZRT Panel 3. It's the least expensive, least comprehensive, easiest to interpret. And then the Dutch Plus that I just showed you an example of before. This is the most expensive, most comprehensive, and hardest to interpret. You get what's called a cortisol awakening response. This is a marker of how well your brain talks to your adrenals. So it's very, very helpful. And here is a ZRT Female Hormone Panel 3 salivary cortisol, and you can see the green line is optimal. Again, the red lines are high and low, and at around noon, this patient is having lowish cortisol, and around midnight, they're having highish cortisol, which can explain why this patient wasn't sleeping well. Here's an example of the Dutch Plus. So this is the cortisol awakening response. So in this graph, you want all of these points to be midway in between this graph. So the cortisol awakening response that would be optimal would rise and then fall. And this person's, and it's 3 points: waking plus 30 minutes, and waking plus 60 minutes. So she starts off low, she comes up to optimal, and she stays high. So this is what's called a high CAR. And anytime a person has a high CAR, that means that they're in a sympathetic state, which is fight or flight state, a high percentage of the time. So this is a very useful type of measurement. And this person has a high-ish nighttime cortisol. This is another pattern that we see often, which is a flat car. So a flat car means that the HPA axis, the hypothalamic pituitary axis, is broken. It is not talking to the adrenals like it should be. It's not sending signals to the adrenals, make cortisol, make cortisol. This is a sign of cortisol resistant. There has been too much high cortisol over too long a period of time, and the brain is saying is just not going to send those fire signals to the adrenals because they know they have to protect the body against high cortisol. So this is a defense mechanism. It shows that there's been higher cortisol for longer periods of time. And this is a very useful marker. So it's really important to look at your heart health. There's an intricate link between heart health and bone loss. And in fact, people with bone loss have been shown to have increased risk of cardiovascular disease, events, and mortality, irrespective of their cardiovascular risk that has been shown in lipids and etc. So we want to look at the genetic components of heart testing. One is LP little a or lipoprotein A. So LP little a is a truck for your LDL cholesterol, and it is mainly genetically determined. It is not lifestyle determined, so you cannot change this. There are some medications that are coming out now. Repatha is one of the medications that will decrease LP little a. Some more are coming onto the market. But pretty much if you have an LP little a that's too high, it means genetically you have a high risk for cardiovascular disease. So what this means for you would be that you want to minimize all the other cardiovascular risk factors that you can to a higher degree than somebody who has a normal LP little a. Apolipoprotein E or ApoE, this is another genetically determined risk factor for cardiovascular disease. And there are 3 different components of the protein. One is E2, E3, and E4. And each one of these pieces of DNA are called alleles. 2 alleles go together to form the protein, and you have 6 different combinations. So you have E2 with itself and with E3 and E4. You have E3 with itself and with E4, and you have E4 with itself. And so different combinations are associated with different responses to saturated fats, actually to the ability or your body's response to statins and your response to dietary saturated fats, and you tend to have a higher cholesterol level. We like to dig deep when it comes to lipid testing. So we don't just do the standard lipids, but we also go into particle size and particle number. And this helps you to have a more advanced cardiovascular risk profile. Apolipoprotein B or ApoB, this is another truck. So a lot of times what we're doing is we're not measuring the cholesterol and the triglycerides directly, but we're also looking at the trucks that truck them around. And that's another surrogate marker, and it dives deeper into risk. And so this is a truck for your cholesterol and triglycerides. We have measures where we can look at whether plaque is initiating and growing. And so the first step of that phase is oxidative stress. F2 isoprostanes is the gold standard for measuring oxidative stress. You have to have oxidative stress in order for the LDL to become oxidized, and it's only oxidized LDL that starts to form plaque. So you can directly measure oxidized LDL and F2 isoprostanes. If your F2 isoprostanes are high, you want to bring more antioxidants into your diet. And then the components that start to initiate plaque and growth, ADMA and SDMA, these are measures of nitric oxide. And nitric oxide is this molecule that helps to keep the blood vessels nice and dilated. And as they're dilated, they're also more elastic. When they're dilated and elastic, blood pressures are lower and event rates are lower. And nitric oxide production starts to decrease in the 50s, in your 50s. And so we can measure it. We can measure ADMA and SDMA. And microalbumin, this is the leaking of albumin, which is a protein in the blood, into the urine. And when that happens, we know this is a measure of a leaky blood vessel. So we want to see what the integrity of the blood vessels look like. We can also measure these components that indicate there could be vulnerable plaque. And so we look at LPPLA2. This looks at the inflammation within the arterial wall below the collagen cap. And that collagen cap is protecting the plaque from not protruding into the lumen, causing a heart attack. And so if there is inflammation in the endothelial wall, you'll see it as an increase in LPPLA2. And then myeloperoxidase is when it's gone even further. So there's inflammation in the arterial wall and it starts to protrude into the lumen. And then we have clots. We have white blood cells and platelets that start to clot that off because that is a direct injury. And that is what's causes a heart attack or a stroke is actually the immune system's response and the clotting that happens. We can do some nutrient testing that is related to cardiovascular disease. So we have Omega Check. Omega Check is looking at your fatty acid sufficiencies, and we can specifically look at omega-3 to omega-6. Omega-3 is anti-inflammatory. Omega-6 is pro-inflammatory. And you want to see that you've got high enough omega-3s. There's something you can do about this. You can add more walnuts or more salmon to your diet. You can add EPA or DHA in the form of fish oils, and you'll actually see your levels of EPA and DHA. And so that can also affect the supplement choice that you make because different supplements have different percentages of EPA to DHA. TMAO is very interesting because it has related to gut dysbiosis. And when it is high, gut dysbiosis is actually affecting the cardiovascular system. And so this is going to give you a higher priority to go after the gut dysbiosis. Not that it's not a high priority already, but it also does show that it's affecting the cardiovascular system. So that pretty much is our content for the day. And we just wanted to briefly tell you about the two programs that we have. I want to tell you about Restore and Rebuild. And we have a special coupon for Margie's community to have $100 off. But basically, this is my signature program. I've been teaching this now for 3 years. I can't tell you how many like good results we've actually had from people. We just had someone who's one of our students. She's had a DEXA scan that has improved 2 years in a row. And we have people telling us that their CTX markers are going down by half. And so this is a 14-week course. It has 10 weeks of live content, 10 weeks of live Q&As. There's so many resources, handouts, self-assessment, progress tools. And this next cohort starts March 7th. It's going to be on Thursdays at 3 p.m. And the URL to get there is themillmanclinic.com/R&R. And so we have an early bird special at $7.97 until February 17th. It's $11.97 after that. And then you can use Margie's coupon, Happy S26100 for $100 off. And this coupon does not expire. And we're going to put this all in the show notes for you. And Margie, do you want to maybe tell them a little bit about our certification program if people are actually practitioners?
Yeah. Well, first of all, the R&R though And you can talk about this after during the Q&A, but people were asking in the chat, and you'll talk about this afterwards in terms of how the lab testing. But this was a way that people were able to do the lab testing, understand their labs, and really move forward on what to do. And yeah, I teach two of the classes in R&R, so I come. It's such a wonderful community. It's just so great. Okay. And then so it's interesting because as I said, I was the one that asked Dr. Millman. I'm like, everyone wants to see you. People asked in the chat, she could only see people, one-on-one if they live in California. However, that's why she started this class. It was like the next best thing to work with Dr. Millman. But then Dr. Millman approached me and said, both Dr. Millman and I, or people want to work one-on-one, they need assistance, they need help, and it's very helpful. And we don't do this, and we didn't have the bandwidth, so we said, you know what, let's train practitioners so that we can have people that understand this incredible integrative approach that's been so effective for Dr. Millman for 15 years, and I've been doing this. And so it's been amazing. We've had our first cohort. It started in October, yeah, I guess, and it's finishing in March. And just these amazing practitioners. It's been such an incredible group of people, and there's so much information. So if you're a practitioner or you know someone who may want to really get this expertise, because Dr. Millman shares her protocols, exactly what she's done. We've written up handouts to use with clients. So it's been just really, right, Dr. Moen, better than we ever expected. Like we had high expectations.
Our clinicians are really are outstanding, and yeah, I think that we've got a group of people who I didn't expect to have this level of really outstanding people. And yeah, I think it's going to be really exciting to have them come in and start. We already have a list of probably already almost 10 people who want help from either R&R or people calling my clinic and being disappointed when they find out that they can only come in when they live in California. And so that's another thing is if you also want help, um, I think they could reach out to your support as well, Margie, right?
Yeah, yeah. If you
If
feel
they
you want
want.
help, yeah.
Mhm.
There are people who already could be helping you. So yeah, so
Yeah.
reach out to support at margiebissinger.com if you but when they are finished, absolutely we'll have them on our, there'll be a way to access them. But anyway,
Yeah.
if you are a practitioner or know anyone that might be interested, we only take 30 people. So it's quite limited and they really get a lot of personal
Okay,
attention. So anyway,
And we
yeah.
don't have the URL here for some
Oh,
strange
all it
reason.
is bonehealthacademy.com.
Yeah, thebonehealthacademy.com.
I'll put it in the chat in a couple minutes. Yeah, so it's just
So
thebonehealthacademy.com.
I think we're ready to actually open this up to Q&As, right?
Okay, yeah. So I'll change the view here.
Okay,
So
well, let me see if
everybody.
I can.
Okay. Okay.
All
Do you
right.
want to just call on people as you see the hands? Is that the best way? Like, before you start though, there were a couple things in the chat that I think are important. So there's some people who are in Canada, and I know you have people in R&R in Canada. So how are they ordering the test? Somebody asked about that.
Yeah, well, that's hard, right? It's socialistic medicine there, and so mainly they have to get their doctors to do it for them.
Okay.
Yeah.
Okay. I guess we'll get started on the yeah, Q&A. Okay.
So my clinic is in Los Gatos, and so it's in the San Francisco Bay Area that Donna was asking. Um, okay, so let's start. We will try to come back around and pick up the questions in the chat, and maybe what we could do is why don't we do two hands and then Margie pick a question in the chat because we're not up to date there yet. So let's start with Jen.
Hi. My question is around the CTX and P1NP markers. could you use those markers to dictate the class of possible medications to augment, the lifestyle interventions? For example, if somebody were 58 years old, just started HRT, 10 years postmenopause, and had CTX scores of 127 and P1NP at 40, um, would it, is it, it just seems like a bisphosphonate would have little room for improvement versus something like an anabolic at negative 2.8 femoral neck.
Yeah, so Margie and I have coined the term short-term medication bridge. This is something that we teach in R&R. So medications should never be, well, they should never be done um, for a lifetime, right? They should be done short term and they should bridge a natural approach to a natural approach. Because if you don't do the natural approach, you won't ever stop the fire that is producing the bone loss to begin with, right? But what you can do is you can use an anabolic for, let's say you use Evenity. Evenity is used for 1 year. Forteo and Timlos, that is used for 1.5 years, and then you need to do something that's rebound. So in my opinion, the only reason to use a bisphosphonate is in a rebound situation, or if there's one other situation, I'll tell you what that is. But and then that rebound for a bisphosphonate is about 1.5 years. So you're like on a medication for about 3 years to bump up your bone mineral density. Now, somebody whose worst case bone mineral density is 3 to 2.8, um, there's no need for medication. HRT can pretty much do that. HRT can improve that bone mineral density. And again, there's no reason, in my opinion, to do a bisphosphonate unless you're using an anabolic. But then there is a couple of reasons. One is if the CTX is exceedingly high, like 900 or something like that, and you want to get that CTX down really fast, you might do a 1 dose of IV reclass to do it. So it's just like help me figure, like give me some time to figure out why the CTX is 900. I'll do this 1 dose of IV reclass, and then everything else will be root cause from that point. But if one of my patients had a femoral neck of negative 2.8 and nothing was, and a CTX that's 100 and something, I wouldn't be recommending a medication to them at all.
Okay, thank you.
Yeah, you're welcome. All right, Kay.
This
Hi
is
there.
Karen. Oh, no,
Hi.
that's Kate.
Oh,
Sorry.
I'm sorry. Yeah, my question was on a supplement. Well, it's a bone building protein called Austenol. And I was wondering if you had ever heard of it and had any opinion about it.
Yeah, I have there's a holistic dentist up in, I think it's San Rafael, who uses it. I don't know much about it. It's supposed to be some sort of like almost a growth factor, like a bone growth factor. It's been around for a long time. It's something that I really haven't looked into that particular product, but I actually have it on my list to look at it at some point. And so thank you for reminding me. But yeah, I don't know, but I do know that this holistic dentist uses it all the time.
Okay. Yeah, I think it does specifically help like with the bone building markers because it is a bone building protein. That's what I understand it to be.
Well, then
So
it probably would affect P1NP more than CTX maybe.
yeah, I think it does.
Yeah, I'm definitely going to be looking into that product. We have a couple of other products that are kind of new, and in the new on the market, and Margie and I are both going to be doing some research on them.
Okay. Do you also ever recommend as far as the heart health portion of it, it's a CT calcium score test
All the
that,
time.
okay,
All the time.
okay.
Yeah. So Evenity is one of the anabolics where, if you know anything about it, there's a black box warning as far as heart attacks and strokes. And what I like to see, before I recommend it, I want to know what somebody's LP little a is, and I want to know what their coronary artery calcium score is. And that is
Uh-huh.
not common practice by an endocrinologist. An endocrinologist is like, yeah, have you ever had a heart attack or stroke? Do you have any symptoms? Okay, you're good to go.
Mm-hmm.
Yeah, and
Mm-hmm.
so I want to know, like, how high is the CAC score? How high is LP little a? I want to know.
Right. I live in the Cleveland, Ohio area, and they offer that calcium score test. University Hospitals offers it free of charge if you get a order from your doctor, because they're running a long-term study just for
That's
other people.
nice. Yeah.
Yeah, that might want to know. Hmm.
Yeah, that's nice. Yeah. And the other thing too is that I know, various radiology facilities here in the Bay Area that don't charge very much for a CAC score. I don't know, is something like $150. So
Hmm.
they're not very expensive. They are their CT scan. There's some radiation to it, but it's a very quick
Hmm.
scan.
Hmm. Okay. Thank you.
I'll do a couple from the
Okay.
so wait, some Diva Boone did their surgery, one of the best in the world. That's great. And someone else said, I have hyperparathyroid. If you have that, you really need to, hopefully you're seeing someone who's a parathyroid surgeon because that doesn't go away otherwise. That's the only treatment. Then someone asked, are these tests covered by insurance?
A lot of them are, if they're from LabCorp and Quest, and that you got a PTH, 24-hour urine calcium. um you have sometimes, but insurance companies will give a hard time about like a homocysteine level, which is, maybe a little bit exotic. Insulin, they have a little bit of a problem with, but in my patients, they're pretty much covered. Except for, okay, the GI map, for if you have Medicare, GI map is covered,
Yes.
something like 50%. Uh-oh, what just happened? Um, the Zoomers are not covered at all, and the Dutch Plus is not covered at all.
Okay, well, one more question here. Most of my daily foods have oxalates. I have two kidney stones several years ago. How many oxalates can most people handle daily?
Yeah, it's around 250 milligrams, something like that. Um, I have
Or you have those great charts.
well, I have. I mean, if I can figure out what I think it's the millmanclinic.com/oxalates is where.
You know what? I will check because I can also share with them the oxalates. Yeah, I'll put something in the replay. Let me find out where we have some good stuff. But maybe is it the millmanclinic.com oxalates?
It might be /oxalates is where they can opt in. And then if they opt in, they get a whole series of oxalate stuff.
Okay, so I'll
Like,
double
they get
check.
the food charts, they get the symptom assessments, they get a whole big long email series where I talk to them about oxalates and kind of how to manage them. And it's a really good little
We'll
email
double
series.
Yeah, we'll double check that, but I'll put whatever the right link is in with the replay when I send it out.
Do oxalates clog arteries? I don't think so. They don't clog arteries. They just lodge in them and cause pain and inflammation. So maybe they could cause some small clots from the inflammation, but mainly they're lodging in other tissues.
Not yet.
You can
Not
see
yet.
with the people here who are raising their hand.
So anybody who's talking, anyone who's talking, can you please mute yourself?
Oh my God.
Thank you. Thank you.
I'm gonna mute too. Let's see.
All right. All right. Should we go with Marlene?
Thank you. My gynecologist told me I couldn't take HRT because I had dense breasts and it could lead to breast cancer. And I listened to you say that was debunked. And the
Oh,
second, so I hope
well,
I got that right.
no, well, let me back up. Okay, so in an appropriate woman without risk factors, estrogen by itself it does not cause breast cancer. It may be the combination of estrogen with progesterone that may add a little bit of extra risk, but we're not even sure of that because the data is mixed. But any time when somebody wants to evaluate whether they should go on HRT, this has to be a very detailed discussion with their doctor about what their risk factors are. And dense breasts do increase the risk. And mainly, I think that it increases the risk because mammograms have a harder time finding the
Yes.
actual breast cancer, right? And so
Mhm.
potentially a person could be either getting MRIs or making sure they're getting ultrasounds and follow it that way. In my practice, I am not saying that I am offering women with dense breast HRT if they want it and if they want to take the risk, and I'm telling them they may have a little extra risk because of that, but it's always a risk benefit analysis, right? So HRT has been shown, it's FDA approved. The patches are FDA approved to prevent fractures. So
Should I consider it if I'm on Geniston? Or are they completely different or separate?
no, they're not completely different. It's the same mechanism. So genistein is a phytoestrogen. It's weak. It attaches to the estrogen beta receptor, and estradiol will attach to both the alpha and to the beta. It's stronger. It will bump genistein off. But genistein is no way going to be as strong as estradiol. But genistein is a really, really good alternative for people who feel like they have too much risk for BHRT, but they want to have some kind of hormonal support.
So that's my answer. I'm going to do the Geniston, and because I'm conservative, not do the HRT now. And hopefully that will give enough protection. Um,
Yeah, it's probably is going to improve bone mineral density by a small amount, not anything like HRT.
so I should consider the patches. This is hard. I have to really delve into this. I know other people have to
Well,
go. It's a tough one.
you should do what you want to do,
Right.
right?
No, it's hard.
But my patients, I have them so within R&R, there's a huge module on understanding your risks where I go through the WHI studies, the elite studies that go through the timing hypothesis, risk factors for everything, and so um, that really um, that really helps some people to understand that.
Okay. Thank you.
Karen?
Yes, hi, thank you. Such good information, a lot to digest. But that's okay, one step at a time.
I basically gave you the basic version of this
That's okay. I think I think we're all quick studies. We'll get there. Question regarding testing. You mentioned Dutch Plus, which is dry urine. Are you familiar with, and what are your thoughts on another one, which is a wet urine test?
Oh, I don't know.
Oh, you don't know that one.
So the thing about the dried urine is it makes the sample stable.
Mm-hmm.
otherwise, if it's a wet urine, then well, there's a couple of different things. So if it's a wet urine, then the sample has to be frozen, and it's going to break down the components that they're looking for are going to break down more quickly. If it's a dry urine, it's pretty stable and it's easy to ship. And with the Dutch, they're looking at multiple points during the day, which approximates a 24-hour urine collection. So that's why I go with that.
Okay. And then with the bone testing, you have DEXA. Are you familiar? You may have heard it's somewhat new is REM, REM,
Yeah,
which
of
does
course.
both bone quality and bone density. So would you recommend that?
Well, that's a whole huge discussion again.
Okay.
So DEXAs are the gold standard, and TBS with the DEXA, TBS is quality. So
Mm-hmm.
with the DEXA, you have bone density and quality with the TBS. REMS does both. And REMS is ultrasound. There are a lot of reasons to do REMS, but I think that what happens is that when you get very conflicting data, and often you do, you, you don't know which to trust. And I'm always going to, I mean, I'm going uh, to favor the DEXA since it is the gold standard more than the REMS. But I think it's if you get REMS that are maybe a little bit different, then maybe you can think maybe you can still interpret it, but you can't ever really directly compare REMS to DEXA.
Right. And when you say conflicting, you might have a DEXA and then you get a REMS and they're different. Is that what you're
Yeah,
saying?
that's what I'm
Okay.
saying. And then what do you do with it?
Oh, I understand. Okay. And then really quickly with and this was a question in the chat, with your program that's coming up, are the tests included in that? No, they're not.
No, it's only 790.
Informative.
It's $797 with $100 off with Margie's coupon, so $697. It's 14 weeks, so I show up for 2 hours for 14 weeks. So
It's educational.
it's educational. Yeah.
Right. Okay. That
Yeah,
makes sense that
but
it's
I do
educational.
have a lab testing guide to tell you how to do these things on your own. So there are companies where you can do direct-to-consumer labs like Life Extensions and Ulta Labs. And also there are immediately when you get into the program, there are tools that you can make that you can use to figure out what are the things that you need right away. And then you can start asking your doctor right away for those things.
Right. So basically, you're in the program, it's educational, and you can basically start from the beginning. What are the basic tests to have done? You build from there.
Right, exactly. And also like, we take things in kind of turn as to more basic getting to more advanced. So, we're starting with the bone turnover markers, which is a good idea to have baseline, and then we are starting to build up, and then parathyroid and calcium and renal leak, and we build up to, into blood sugar, into stress, into cortisol, into gut, we build up. So it
Right.
doesn't
So
have to
yeah,
all be done at the same time.
exactly. And that would is what you would do if we came in person to see you. I live in California, so
Yeah,
I'm
it's
lucky.
basically
So
what,
that's
yeah,
yeah,
yeah.
that's you would start the same. Okay,
Well,
understood.
not exactly. Not exactly. I mean, I would lump all of the LabCorp and Quest stuff together and get it all in and like have it all. And then I would probably order all the functional but I'm very impacted from my schedule point of view, and I can't get people in for, you know, like it's like their appointments are like 3 to 4 months.
Mm.
And so I gotta get as much data. I'm actually looking for a coach to help me. So,
Out
but
of the first time around, out of the gate.
yeah,
Yeah,
yeah, yeah.
understood.
But
You
but you can't get in to see me until June, I don't think.
I see.
and you have a lot of
Great.
people, Dr.
And
Millman, who take the
thank you.
course and see you.
Yeah,
You
I
have
do. I have a lot of people who do that. A lot of people. In fact, you can't go to see me anymore without taking the class. Because there's too much that I need to describe to you, and it's all in the class. And from my point of view, you actually save money because otherwise it would take us twice or three times as long to get through the appointments. And you're like listening to me like weekly, right? And you get to ask questions weekly.
Understood. Thank you so much.
Yeah.
One more thing I think it's important to tell people, like early on, you'll get the whole list of testing, and not everybody does all the testing. You don't have to do every single thing,
Yeah.
but early on, you see what works for you. But early on, you'll give everybody the list so that it makes it easy.
Well, they have the web tool, right? So they have the web tool that figures out what they need to get. So somebody's asking how often. It's twice a year. So we do it in March and is it September that we do it? October. I don't remember if it's September, October. The web tool. All right. I wasn't going to give you guys the web tool, but I guess I will. Should I give it to them? Should I give you guys the web tool?
Yes.
Carol is like, I'm not saying no. Okay, let's see. Somebody's going to have to tell me if this is the right. I think it's the right. I can actually show it to you. You guys see if that's the right one. Richard's here. Richard can tell you if that's the right one. Okay, let's move on. Okay, Linda. Linda, you just emailed me recently, didn't you?
I did, and I already applied for the program, but I thought the program started this Monday.
No. March 7th. No, it starts
No,
March
I'm
7th.
talking I want to do both programs is what I'm thinking. And was part of my question. Is there an incentive or
Oh, do you want to do the certification program?
Yes, I'm a functional medicine and integrative health coach. And yeah.
Well, so this is what I would
want to. I just
There's your
need to look
coach.
at timing and
So this is what I would recommend. If you take R&R now, we will give you a credit for the certification because the certification program is not going to start until probably May, and a lot of the education is from R&R. So if you start R&R March 7th, that's going to give you 2 months head start on the education part of it. And then you'll get a credit for it when you take the certification program.
How much is the certification program and the length of that program?
So that's 6 months, and that is 5,000.
And can it be paid out?
Yes.
Okay.
The other thing is, though, if you don't feel like doing that, you can just wait. You're not going to learn anything in R&R that you aren't going to learn in the certification. So if you don't want to do this right away in March, just you can wait till May and do the certification. But or if you want to start, like Dr. Millman said, and start with R&R.
So what the cost of the R&R would go toward the certification program?
Yeah, whatever you pay for, if you want to use Margie's coupon and get $100 off, then $697 would be applied to the 5,000.
Okay, I have to figure.
And by the way, we would love to have you.
And I've been looking for something niche, and I thought I was going to do Hashimoto's because I have Hashimoto's, but I imagine this is going to help me with that too. So
it is, yeah.
And both my mom and grandmother had osteoporosis. I have osteopenia. I'm 63, and so my girlfriend who follows you, Margie, she's the one that told me to follow you. And she just did her bone marker. She did a 1-year commitment to Onera, and she's also did the nutrition. And she her numbers are so much better. And we want to start a podcast together on aging. So yeah. So personally, I want to be the testimony to helping others.
So if you want, I'm happy to meet with you. I'm happy to one-on-one meet with you and really go through things if you want. So
please, that would be great.
Write to support@margiebissinger.com and we'll schedule like a 15, a meeting so we can go into
Okay.
detail. Because yeah, that you sound like the perfect person to do this. Yeah. And it's fun, right, Dr. Millman? We are like loving, we're just so happy when we have practitioners.
Well, I would just make I would just say that you can't find better people to work with than people with bone loss. I just can't say enough about how sweet the women are in my practice and in R&R and here with you, you'll see these people, right? I mean,
Good. Well,
they're
I teach Pilates and I'm starting to work with more people with osteoporosis. So I think, yeah, this is, how something just comes in your inbox or whatever. And I'm so excited about this now. So, and I've
oh
been
good.
studying functional medicine with the School of Applied Functional Medicine. So I've got,
You
yeah,
have the background. Yeah, great.
but I need more knowledge. So yeah. Thank
Well,
you.
Well, I think what we give you it's hard to find anywhere else is, like everything is through the bone lens, right? It's just it's all through that lens. And the turnkey programs that we're developing are to help the practitioner. They're phenomenal, if I can say so.
you can
They're
see we
really
don't like the program too much. I'm just teasing.
No, of course you're going to be proud of what you're.
Appointment, yeah, make the
well,
appointment.
yeah, I mean, like we've worked really hard. We've worked really hard.
It's funny. When Dr. Millman approached me, I was like, oh, it was a no-brainer. Like there was no way in a million years that I was not going to do this. So anyway, it's really fun. But yeah, that would be great. So we'll continue the discussion.
Thank you.
So Susan and Stephen already want to know when your podcast is gonna start.
Yeah, and do the podcast. One of the best things you'll
Well,
ever
I
do.
need to know which microphone to buy. I kind of picked a $550 one, but every time I spend money, my husband's like, "Do you know how much money you've spent on, your health coaching and Pilates and everything I do?" And I'm a massage therapist. Like, I'm like, how many certifications can I have? But you have to do what gets you excited in the morning, right?
Well, it starts to pay off at some point, and you do have to invest. And I mean, I don't think I made a penny for at least 7, 8 years,
Mm-hmm.
and I'm an MD. I mean, so we all go through it.
Mm-hmm.
Okay. Okay. Well, so yeah, contact me at Linda. All right,
All
yeah,
right, Pam.
Pam's next. Pam, you're on.
Okay, yeah, I'm here. I'm here. I was like going, I was so busy reading the chat. Okay, I wanted to ask you, this is great. So thank you so much for creating it. I had my DEXA scan and I had a left hip at minus 3.3 and femoral neck at minus 3.5. And 2 years before that, the femoral neck was 2.5 minus 2.5, so I increased a lot. So the doctors wanted to put me on Fosamax, and I also had my CTX was 308. This was in October, and my P1NP was 51. So I've done 3 months of Fosamax, and my CTX is 71. I couldn't even believe that it went from
Oh.
308
Well,
to
it should
71.
do that, and that's what the bisphosphonates are meant to do is drop the CTX, but they don't build very much quality. So they will build a little bit of bone mineral density. They will not build very much quality at all, not
Yeah,
at all.
that's what people have told me. And then so it worries me.
And a bisphosphonate, in my opinion, is not strong enough for somebody with a negative 3.5. In my world, that's a red flag. And that is somebody who needs an anabolic in my world. And
Yeah,
I'm not giving you medical advice. I'm just telling you that in my practice, that's what I would be recommending for for a patient.
yeah, that's great to know. So which anabolic would you do? Because people talk about Evenity for a year, and then they also talk about Timlos and the other
Yeah.
one.
I'm a big Evenity fan. I
Oh,
mean,
you are? Okay.
I just had a patient who, now it does work better on the spine than the hip. But I just had a patient, she had an 18% increase in her lumbar spine in 10 months.
Oh, that's
Crazy,
great.
crazy numbers, crazy numbers. But I did look at her LP little a and I looked at her CAC score and and I am the one that said that she was okay to do Evenity. But I mean, a bisphosphonate is going to definitely stabilize things, but once you do a bisphosphonate for too long, you're not going to be able to do an anabolic for a while. You have to stop the bisphosphonate and let the bones open back up. It's like the bisphosphonate closes and
Yeah.
seals the bones, and then you have to stop it, let the bones back open back up again. So you gotta watch that CTX. That CTX has to go back up into the 350, 400 range before you could even start something like Evenity. You have to watch that CTX
Oh, why does CTX have to go back up after all this work getting it down?
because the anabolics don't work as well when the bisphosphonate is the bisphosphonate stops the anabolics from working.
Ah,
So you
okay.
have to get the effect of the bisphosphonate off the bone. And so whether that takes 3 months, 6 months, and the way you can monitor is seeing the CTX coming back up again.
Yeah, okay, great. Yeah, because I went from, yeah, I had been 227 in August, 308 in October, and then came down to 71 now. So I'm
I
wondering if
mean,
I,
that should happen. That's the normal path, but whether that's the right drug for a person that's in your situation,
yeah, no, well,
I wouldn't have done that in my clinic.
yeah,
I don't use
unfortunately,
I don't use bisphosphonates unless it's a rebound.
right, right.
I
Yeah,
don't
that's what a lot of
because
people
they
say.
don't build quality.
Yeah. The other thing is my CT score is a 0. So I had like a perfect score on
That's
my
great.
coronary artery score.
That's great.
So yeah, and then also I have low cholesterol. I take a rosuvastatin. And then what about HRT? I'm 74 and I asked my gynecologist to take HRT and at first he didn't want to give it to me. But then he said, well, if you want to take it, it's fine. So he prescribed a 0.25 patch with 100 milligram progesterone. But somebody said that 0.25 isn't going to do too much for bone density.
Well, I want to be careful because there's so much personal data that's being shared here that if I give much more information that's specific to you, you can't but consider this to be medical advice, and I have to protect my license. But I can say that HRT is extremely good for building bone, and I usually start my patients at 0.0375 patches with 100 milligrams of progesterone, and then I look at adding testosterone later. I have a patient who I show kind of her case study in R&R as what you can do with hormones, but she just completed 4 years on hormones, and she went really slow too. And she had a 13.5% increase in her lumbar spine in 4 years. And well, I did other stuff, gut and food sensitivities and all that stuff, but it was mainly hormones. And then she did a little bit of weight training.
Yeah, yeah. Yeah, it's hard when you're going through all this to know which thing is the best thing to do.
I
And
know, I know,
yeah, so and that's
I
why
know.
I'm so happy that Margie offered this because I do these when there's somebody talking about it. There's a menopause thing going on right now too, and it really helps to kind of learn because it's so hard to know what to do, which is best. But
I know.
many people have told me the bisphosphonates aren't going to be strong enough. And what's really funny is the rheumatologist said that I'm in her notes. She wrote that I'm treatment naive. That's what she wrote on my notes. I couldn't believe it because she said I declined to take Fosamax because they told me 3 years ago to take it. So anyway, so yeah, all right. Well, it's
Well, I
great.
mean, that could be true. I mean, it could be true that you don't know enough about medication to know that the bisphosphonates are not going to be very helpful in a
Right. Yeah.
situation like yours. But yeah, I'm agreeing. I'm agreeing with Carrie. We were going to have to,
Yeah, keep going, keep going. Thank you.
yeah,
Thanks for
you're
your help.
welcome.
Okay.
Okay, Reverend Laura.
Sorry, I thought I was going to have to go first. I am curious about the C something CTX. Where do you get those labs? Is that like from LabCorp or is that a specialty lab? I've not heard of that one before.
Yeah, so CTX is the acronym and it stands for C-telopeptide. And you can get that at LabCorp or Quest. And you can ask your doctors for it.
Okay.
Sometimes they will do it, sometimes they won't do it.
All right. Because I just got my DEXA scan results today from last week, and so I would be curious to see what that is for a starting point, like you mentioned. The other thing is I've
It'd be a
recently
very appropriate time, yeah.
okay, so now would be a good time to ask for that then?
Yes.
Yep. Also, I've been to, I don't remember if I saw them at IFM or A4M, I forget which one, but I think it was Bonita or some type of a probiotic to help with building bones. Do you know much about that? Is that working? Because I haven't heard you say much about that.
L-reuteri is the one that is really I think L-reuteri is most specific for bones, and you can get L-reuteri uh, you know,
I think they were using lactobacillus, but if it's L-reuteri, I can look for those. I just didn't know if
well
it all had to be medications.
L is lactobacillus.
Yeah.
Right. So L-reuteri is Lactobacillus reuteri.
Oh, it's just a different flavor. Okay.
Yeah.
All right. Different. All right. Thank you.
Okay. Yeah. And all right. LGV. I don't know. That could be somebody's device that they're on. Maybe it's not their name. I'm not sure.
I see Willa with a hand up, do you say?
Shilajit, I think is something that helps the minerals to absorb or maybe to work better. There's a Quicksilver product that has Shilajit that I use some. It's a complex mineral, so I like Shilajit. I don't know how to pronounce it.
Okay, how about Willa? I'm bringing her up. Okay,
Willa, Willa.
you're on, Willa.
Hi, thank you. I'm really enjoying this. I'm 58 and I've been on HRT for over a year. I am I have osteopenia. Um, Asking my doctor to run hormone test is like pulling teeth. They
Yeah,
just don't seem to want to run them.
yeah.
And I was at my endocrinologist and I asked for estradiol, had to beg for CTX and what is it, P1 and P, and she reluctantly agreed to test them. So I have those results. My CTX is great. It's like 102. Estradiol is at 60, but my
60, six
NP,
zero,
I'm
six
sorry,
zero, 60.
the CTX.
No,
Or
estradiol was 60, 60.
no, my estradiol was 60, 61. My CTX was 102 and the P1NP was only 20. So I'm not building bone. And I guess my question is
Yeah, you are.
if I am, but even
Yeah.
at that level,
Yeah.
I did
So
a higher level.
So CTX should be optimally 250 to 350. So 1 and 2 is a little bit low. So you got to kind of look at, in my practice, what I do is look at maybe a hypometabolic state that is causing the CTX to be low at 102. P1NP should be at least 1/10 of CTX. They go up and down together. So,
Okay.
so if the CTX is 102, then a tenth is 10.2, and a P1NP of 20 is twice that high. So P1NP is good, is great. CTX is a little low, but I don't worry as much about low CTXs as I do highs.
Okay. And is there like any going up? I'm on a 0.05 milligram patch. If I went up in estrogen, would that help me build more bone? Because I've heard that you can actually, if you optimize estrogen, is that something to continue to push for?
So this gets into a really, really complicated sort of discussion, but I'll give you a little bit of background. So CTX mainly is anti-resorptive, which means estradiol is mainly anti-resorptive, which means that estradiol should be decreasing the CTX. When the CTX is 102, estradiol is good.
Okay.
So estradiol doesn't help you to build bone. It helps to prevent bone breakdown. Progesterone and testosterone help you to build bone. P1NP is already twice CTX. So pretty much those are good numbers.
Okay.
Now, if I have a patient who has a CTX of 102, I'm going to look at potentially low iron, low B vitamins, anemia, sluggish liver, blood sugar irregularities. I'm going to look at anything that could make somebody hypometabolic, and
Okay.
mostly iron and B vitamins
Okay.
and
And
thyroid and low thyroid.
okay, that's good. And then pushing, like I've asked for testosterone and I'm getting like this blank stare. We don't do that. Is that something I should continue to push for at this point? It would taking DHEAS help give me that testosterone?
DHEA helps with DHEA will help with the production of estradiol and testosterone. Um, Estradiol levels in the 60s. If it's a young woman, I'm okay with estradiol levels being that high. Older women, I am not okay with an estradiol level of 60. Estradiols can backtrack into testosterone when the levels are high like that. And so I want to see if somebody is on BHRT, I want to see a testosterone of 40. That's going to optimize the bone growth. And I want to see a DHEA around 120 to 140.
Wonderful. Thank you so much. This has been so helpful.
Yeah, and in my class we do all this
Oh, that's wonderful.
for
Great.
14.
Thank
We do all this for 14 weeks.
you get into the nitty-gritties with all the hormones and then
Oh
that's
yeah.
wonderful. Great. Okay. Thank you so much.
Carol, I'm bringing Carol up. Oh.
Let me talk about fenugreek. So Moira is asking a lot of good questions. I have so one of the big things for testosterone is high zinc levels. So zinc at about 70 milligrams or so of zinc will help with testosterone. Maybe it's 50, but I use a metabolic code product called Tea Time, and that helps to increase testosterone. It does have fenugreek in it. Has I think it's got tribulus and fenugreek and zinc and I can't remember what else it has in it, but those are all kind of natural things to boost up testosterone. But I do that too.
Cool.
Okay, Carol's
How
coming
are
up.
you?
Oh, thank you.
You're good. Okay.
Can you hear me okay?
Yes.
Um,
First, I
This
want
is
to
really long
say,
meeting. Oh, can I clear this up because I think I've got some people confused. Okay. So
oh,
March 7th is a Saturday. And what happens is that the content drops on Saturdays. And then we get together on Thursdays for Q&As. And so the first content drop is on the 7th. The first Q&A is that next Thursday live, and we talk about what we just dropped on the Saturday. So that's why it starts on a Saturday. Which we're not live on a Saturday. We're live on Thursdays. Yeah, you're welcome. All right, Carol?
thank you for doing this. It's been very educational. I won't be able to take the webinar until September.
Okay.
But first of all, I want to know, is it too late to do these things when you're an 81-year-old?
No, I actually have a couple of patients who are on HRT and they're in their 80s.
Okay, so it looks, I have a lot to learn and a lot to do to take care of me, but I have a specific question. I participate in medical studies fairly often, as long as they're not invasive. And I just had completed this fall an Alzheimer's study, and I did some blood work and discovered that my B12 was 189 below
Wow.
the US standard. That's too low. I had a problem with that 10 years ago. The neurologist in charge of the study sent a letter to show my doctor recommending injectable B12. He said that oral, I talked to him too, and because it would take a while to see the doctor and get that going, I started taking sublingual methylcobalamin. I don't want anything to do with cyanocobalamin, which is a standard here and banned in Europe and Japan because it's synthetic. And I had previously, 10 years ago, used injectable methylcobalamin. So I went to the doctor. I was taking, or what I'm taking right now to hopefully do something, is 5,000 micrograms sublingual. And she told me that was too much. I could get sick. And I told her it's a water soluble vitamin. And your body excretes what it can't use.
Yeah, I would have to agree with that.
And then she sent me for some blood work, and that included a B12 test, which, of course, because I was taking sublingual methylcobalamin, showed a blood level of 2,000.
Yeah, that happens a lot to my patients, and I tell them to worry about it. Just keep on your B12.
Oh yeah, blood serum. I read studies. I used to work a job where I prepared studies in neuroscience. So I read that the blood serum B12 test is notoriously unreliable. And it certainly was just measuring what was in my bloodstream. But she refused to order injectable B12. I have had chronic long-term gut issues. I've been aware of that. At various times, I've tried to treat it. I haven't been that successful, so I asked for a GI consult. And I got to talk to a nurse practitioner whose basic recommendation, she did add some blood work to see if I have the genetic marker for celiac disease. I've been intolerant of gluten now since 1989. And then recommended the FODMAPs diet. And that's only part of the problem I probably have with my gut. I know that I probably have the unfriendly bacteria, all of those kind of things.
Yeah.
But my question is it more effective to do injectable methylcobalamin, which I'll have to fight for, of course?
No, so if a person's serum B12 level is 2,000, then they're obviously absorbing the B12.
Okay, so I could continue with that and not pressure for injectable, correct?
I'm not going to give you medical advice, but
Oh, that's right. Yeah.
but I will say that there's the only way that the serum level of B12 is greater than 2000 is if somebody absorbed it, right? It's in the blood. It's in the blood.
Okay. Okay, so I
Right?
will.
So the
Thank
only
you.
reason why you give injectable B12 is because you can't absorb it. Well, and one way to get around that, which
Yeah.
you were, quite astute enough to figure out, was the sublingual
Oh, yeah.
way is, there's a lot of blood vessels in the mouth, right? And
Right.
that's one way to be able to absorb
Um,
things. Yeah.
Well, my guess is that I have malabsorption of a whole lot of things. I have a very hard time maintaining adequate levels of zinc.
Could be.
So I will be, and I live near you, not that far in the East Bay. So
Oh, okay.
down the road, I will be hopefully visiting you. I have decided my provider is Kaiser, and they are doing as little as possible for me.
Yeah.
So I will be in the process of finding a physician that will take Medicare, find out which supplement they accept, and change my provider within the next 3 months as a kind of first step.
Well, Carol, thanks for sharing all that. We're going to have to move along to somebody.
Thank you.
So we're only going to stay an hour and a half, but this always happens to Dr. Millman and I. So we'll stay another 10 minutes, which will be 2 hours. I just want to tell you, everybody, that Dr. Millman is coming back and she's doing another free webinar, just Q&A, and that's going to be on February. So if you didn't get your questions answered, but she's doing a great job, February 26th at 6 o'clock Eastern time. So that's going to be, right? That's going to be 3 o'clock Pacific time. Right, Dr. Millman? That's hard. That's on Thursday.
I don't know. I don't know when I'm coming back.
Yeah.
I would have to have my calendar open. I'm
We
sorry.
decided 6 o'clock.
Um,
Yeah, so
yeah,
really,
but yeah, please do come for the Q&A. Yeah, because we're pretty much we're gonna hit all the topics.
Jane has her hand up, so let's just answer Jane.
Jane,
Thank you. This will be quick. And I know you can't give medical advice, so I'm not really asking for that. And I did sign up for your
Oh,
100-day
great.
course,
I
so
saw
I'm
your
excited
name.
about that.
I saw your name. Awesome.
Good. My question is, and basically just some kind of reassurance because I feel guilty. So I'm 72 and I had a DEXA and in November, and my spine was minus 1.3 and the hip was minus 2.0. And my doctor wants me to start on reclass based on the FRAX score. And I don't know if I want to do that. But I feel guilty because she says, well, you could
Wait. Okay, so
and I'm on HRT.
Repeat the DEXA again.
The DEXA in my spine was minus 1.3.
So that's osteopenia. Why do you need why do you need IV reclass for osteopenia? And then
that's what I was wondering.
And then what was the other level?
Minus 2 in my hip.
Osteopenia. No one needs a bisphosphonate for osteopenia.
Okay.
So my 3 red flags are these: greater than negative 3.5, somewhere in the body. Equal to or greater than 900 or 800 for CTX, or a person's fractured. Now, if any of those criteria are met, people need to really seriously think about medications. Again, so the one instance where I say that somebody should do like IV reclass first would be if their CTX was 900 and we didn't know why. Or CTX is 900 and we do know why, but we can't do anything about it. The one instance where I can tell you is like I've had patients who have breast cancer histories and they're on anastrozole, which totally shuts down the estradiol. Their CTX goes up to like 1100. And what are you going to do? You can't take that patient off of anastrozole, right? So those patients, I will say, do a year or 2 years of IV reclass to keep your CTX down so you're not like breaking down your bones like crazy while you have to be on this drug. Wait till you're done with the drug and then let's try to do an anabolic.
Okay,
Or
and
do
I
or
do
do an
take estradiol.
or do an anabolic. You do
Okay,
something, right?
yeah,
If somebody cannot
yeah.
leave their CTX at 900, 1100, that is not advisable.
Okay.
So, but if a person doesn't have any of those red flags, I don't
Mhm.
recommend bisphosphonates at all except for rebound. And somebody
Okay.
did ask the question, does Evenity have a rebound? Evenity has a rebound. It's mild. Forteo and Tymlos have rebounds. They're pretty mild. Prolia has the worst rebound. And it's not an anabolic. So I don't use Prolia very often at all.
Yeah. Okay, and I haven't had any fractures.
And we have a
And
we have a
Mhm.
big we have a brand new module on medications in R&R.
Great. I'm looking forward to it. Thank you very
Yeah, I'm
much.
looking forward to
And
having
I
you
just want to
too.
say that, this is a prime example why we have to be knowledgeable. Because if you just, there really was no reason that you should, I mean, that's not criteria. And, but a lot of times people are like, okay, that's what they say. I have to do that. So that's why it's so important to understand, have the knowledge, and be a partner in this.
And
And I so appreciate this.
isn't it terrible that she feels guilty?
Yeah.
Yes, you should not feel guilty. Feel empowered and smart. Yes.
Thank you so much.
Should not feel guilty.
I think we're good. Is there any, did we answer? I think we got pretty much everything.
No, I don't have a module on radiation bone effects. It's too specific. Yeah, unfortunately, I don't. I think you just have to treat it as being very inflammatory. Can you recover? I hope so. I think so. There is a homeopathic that I use for radiation. It's called HVS. I don't know if you can get it as a consumer, but it's called HVS radiation, and I do have my patients do a capful every day of it. Feminescence, yeah, I like feminescence. I recommend it. It's in R&R. Repeat the red flags, negative 3.5 or worse, CTX 800 to 900 or worse, history of fracture. A CAC angiography score, say no to Evenity, that's a hard one. Maybe, I talked to Dr. McCormick about he was thinking 100. I think maybe even a little more, maybe 150. Um, Optimal estradiol testosterone DHEA so DHEA 120 to 140, testosterone 40, about 40. Estradiol depends on whether you're older or younger. The ranges should differ according to the timing hypothesis and the elite study. Yeah, Margie talks about exercises. Yeah.
Oh, absolutely. Yeah, I do exercise and I do stress reduction as part of R&R. Yeah.
Yeah. Mm-hmm.
On the practitioner program, we go in detail.
Uh,
Okay.
T-score -5. -5 is medication land, in my opinion.
Yeah, I think
Wild yam cream is a hormone replacement. I mean, you can get some from that. Red flag -3.5 at any site on a DEXA scan or worse. I don't do the provocative urine tests for heavy metals. I do the total tox by Vibrant America, and they're looking at urine levels.
Okay, just like another minute. Why don't you answer like one or two more quickly?
Yes, we're going to send out a link for the replay.
Yep, the replay.
The
And,
guide,
and you
the guide,
probably,
the
and you're getting the
guide.
guide, and we'll get the oxalates. You're getting so much stuff coming. It may not be tomorrow. It may be, it will be within the next 2 days because I'm going to put it on a different sheet with I'm going to put it all together. So the links will be with the sheet and everything.
I wouldn't worry about a phytoestrogen with a cardiovascular disease. No, I wouldn't worry about that. No. Red flag was negative 3.5. Negative 3.5. Negative 3.5 is on any site on the DEXA. So lumbar spine, negative 3.5 or worse. Femoral neck, negative 3.55 or worse.
Okay.
Okay, let's see. Please, can you answer this? Oh, you're in Spain. I've actually had people in Spain take R&R. The issue is that 3 o'clock Pacific on Thursdays are the times of the live Q&As. Usually somebody in Spain is not able to do that live. There are replays on every class, and there also are pre-submitted questions. So yeah, so there are pre-submitted questions. So even if you can't make it, you can submit your question. I'll answer it. You'll hear the answer in the replay. But if you don't like the idea that you won't be able, if you can't like get up in the middle of the night and listen to it, or and you don't like the idea of it, then you have to make your own decision. 52 and already have osteoporosis even before menopause. Yeah, that's a little suspicious of, I would say, gluten problems. Yeah, gluten problems, not achieving peak bone mass before. Um, Less than negative 3.5, no RX. No, I'm not saying no RX for less than 3.5. I'm just saying that those three criteria, if any of them are there, I'm really talking to my patients about, do you want to consider medication? Earlier than that, people might consider it as well. I have some patients who are very physically fit who want to, and they want to achieve a standard deviation in their spine that they don't think they can do any other way. HRT can probably build zero point 0.8 standard deviations in your spine, but probably not a full standard deviation. So it's just a weighing and balancing kind of thing.
Okay, Dr. Millman, we're done tonight.
Oh,
Dr.
Avenity or reclass for -5, Avenity. But I'm not giving anybody medical advice.
Yeah, how Dr. Millman does it in the classes, you have to, there's a format. If a person had this, so that it's not medical advice. Anyway, so everybody come back on the screen who wants to come back.
Yes, I do have people in Canada that could be study buddies, but they're one of them is coming back as an alumni.
Anyway, the way I like to end my classes is we pick a word. We always say, bye, thank you, Dr. Millman. Is there a word you want to pick one, Dr. Millman? What should we say? Strong bones, empowered. What's coming to you?
I think hope.
Hope. Okay. I love hope. Okay. All right. So everybody, thank you. Again, I'll give you there will be an opt-in for the Q&A coming up just so we know how many people. But anyway, yeah, so you'll get the replay now that you're going to get the oxalates. You'll get the really good tool that Dr. Millman talked about with the
Yeah.
different, it's pretty impressive. So you'll see that.
Yeah.
That will be coming. And yeah.
On the tool, I'm actually going to give you what I'll do both in the oxalates. The oxalate is an email series, so you have to like put in your name and your email and that kind of thing. And for the tool, you'll have to do that too. But spam people. And if I send you something about a promo, it'll probably just be about the class. So, I mean, I don't send out very many emails at all. So you don't have to worry about not putting in your email address.
Anyway, all right, everybody. Thank you so much, Dr. Millman. This has been so incredible.
Thank you.
Thank you, everybody, for hanging.
Thank
in.
you.
Thank
And
you.
Hope. Thank you.
Thank
Thank
you.
you.
Thank you very much.
Bye.
Hope. Thank you.
Bye, everybody.
Hope.
Good to see you all.
Bye.
Ready?
Bye.
1, 2, 3.
All right.
Hope.
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 Bye.
Bye, everybody.
Bye. Thank you.
Bye.
So welcome. And if anybody's on YouTube and you want the replay, well, I guess it will be on YouTube. Otherwise, you can write to support@margiebissinger.com and we'll send you all the information. Okay.
Thank you for Hope. Bye-bye.
Bye.
Bye.
Bye. Okay, I'm just gonna save the chat. There was lots of juicy stuff in the chat.